All right, repetitive strain injuries. Presumably, you guys look after these cases a lot, right? Okay, so by definition, it's conditions resulting from repetitive tasks, forceful exertions, vibrations, compression, or sustained and or repetitive awkward positions. And basically, it's injuries encountered in the workplace. And the incidence since the 1970s has increased dramatically because of the use of computers and initially typewriters and now computers. So we see them not infrequently, and the RSIs are classified or divided into two types. Type 1 RSIs, your typical upper extremity repetitive strain injury, and includes everything from carpal tunnel syndrome to finger tendonitis to epicondylitis to rotator cuff disease. The type 2 repetitive strain injuries is the diffuse or non-specific pain syndromes or chronic non-specific musculoskeletal pain, where these patients have diffuse pain, and radiologically and clinically, you really can't come up with a definitive diagnosis. And I'll just touch very briefly on the type 2 RSIs, but spend most of the time on the type 1 RSIs, because that's what you guys see all the time, and it's important to know what it looks like on imaging. Who cares? Well, the US government cares. $60 billion annually is spent in looking after patients with RSIs. It's 29% of all workforce-related injuries requiring time away from work. Major source of litigation, and can be quite, significantly decreased by having an ergonomically designed workplace or workplace material. Most often affects the upper extremity. So these are the classic repetitive strain injuries: finger tendonitis, trigger finger, carpal tunnel syndrome, Decker veins, Tenosynovitis, intersection syndromes. Do you guys diagnose intersection syndromes a lot? Yeah, okay. It's actually not uncommon. It's fairly common. Cubital and radial tunnel syndromes, medial and lateral epicondylitis, bursitis and rotator cuff disease, focal dystonia. I'll wait until he passes. Okay, so carpal tunnel syndrome, very common. Lifetime incidence, people say anywhere between 10 and 15%. Female is much more effective than males, 3-to-1 ratio. And theoretically more common in typists and computer users, radiology and radiology residents, theoretically, because we use a lot of computers. So the etiology of carpal tunnel syndrome, vast majority of patients with carpal tunnel syndrome, you have no underlying cause. It's an idiopathic etiology. But you can have mass lesions which gets into the carpal tunnel, which causes a secondary form of carpal tunnel syndrome. And I've highlighted a couple of the main ones that we see. And I've highlighted the persistent median artery because a lot of people don't know about that. One, as a cause of carpal tunnel syndrome, and two, as a complication of carpal tunnel syndrome surgery. Tenosynovitis of flexor tendons, and anything that causes masses within the carpal tunnel. Lipomas, neofibromas, blah, blah, blah. So on imaging, clinically positive Tinel sign and Phelan maneuver, which you guys know. And then on imaging, essentially what is going to happen is the nerve, the median nerve, as it comes down, is going to have upstream dilatation. So you're going to get enlargement of the nerve, edema of the nerve, and if you give contrast, enhancement of the nerve, proximal to the carpal tunnel, and then as it gets into the carpal tunnel, it sort of tapers off and flattens down. So it's not enlarged. Majority of the enlargement of the nerve is actually proximal to the carpal tunnel, even though it is a little bit enlarged in the carpal tunnel. So these, just to let you have an orientation, these are axial fat-suppressed T2 weighted images of the wrist. This is a sagittal T2 weighted image. So that's the fat that's suppressed. This is the bone that's suppressed. This is the median nerve. And you can recognize the median nerve by the fascicular pattern. Do you see the fascicles of the nerve here? Not to be confused with vessels nearby. And the tendons are going to be black. These dark structures are the tendons. So proximal to the carpal tunnel, you can appreciate how large it is. Then as you get distally into the carpal tunnel, it actually kind of flattens out inside of the carpal tunnel. So that's a typical appearance. And if you look at the sagittal images, it demonstrates it even better. There's upstream dilatation of the nerve, and then as it gets into the carpal tunnel, it sort of tapers out in the carpal tunnel, right? So it's like it's compressing and dilating more proximally. That's a typical appearance of an enlarged median nerve in carpal tunnel syndrome. With contrast, this is before contrast, and this is with contrast, it enhances pretty significantly. What has been described as, actually described by a guy by the name of Ms. Garza. That he was a radiologist at Temple back in 1989. They described this this sign where they looked for palmar bowing of the flexor retinaculum. So on T1, T2 weighted images, this is the carpal tunnel here, and these are the tendons. The black structures are the tendons, and the white structure is the nerve. And with the enlargement of the nerve, the mass effect, you get bowing of the flexor retinaculum. And true bowing of the flexor retinaculum, and I don't expect you to remember this, but in essence, what you do is you measure that distance, you measure this distance between the hamate and the tubercle of the triquetrum and the flexor retinaculum. The ratio of that to that, if it's more than 0.15, it's true bowing of the flexor retinaculum, which means that there's mass effect in the carpal tunnel and it's pushing the retinaculum outwards.
You said that was from hamate to...
From the hamate to the triquetrum, yes. Yes. The persistent median artery. Now, this is actually under-recognized. It's a branch of the ulnar artery. It's present in about 10% of the patient population. These are T1s, these are T2s. Images look really grainy, and these are T1s with contrast. So if you look here, the black is the tendons, correct? This gray area on the T1, that's the nerve. And then at the T2, see this little bright structure? That's the persistent median artery. And that artery can lie, it always lies within the epineurium. So it lies within the nerve itself, just outside the fibers contained by the epineurium of the nerve. So if you have overuse, if you're overusing your hands, you can get dilatation of that artery, and that dilatation of the artery can cause compression of the median nerve, and you can get a carpal tunnel syndrome. But even more importantly, when you go in to resect or divide the flexor retinaculum for carpal tunnel syndrome, there are cases where you can actually transect the artery and you get a lot of bleeding and surgery. So it's important to know about the persistent median artery as a cause of carpal tunnel syndrome and also a complication of carpal tunnel surgery. Another example here, a really big one, big artery inside of the nerve. The black is really not projecting very well, but the black are the tendons. This nerve is here, and that's the big artery in the nerve. And if the nerve is bifid, which is not uncommon, the median nerve can be bifid inside of the carpal tunnel. If you have a persistent median artery, it tends to be centrally located within the nerve. Okay, so you have the two fascicles of the bifid nerve, and the artery lies dead in between the two. You guys do ultrasound, don't you?
Yes.
Do you do it for carpal tunnel syndrome?
Yes.
Okay. Okay. What criteria do you use to make your diagnosis of carpal tunnel syndrome on ultrasound?
I like the ratio at the inlet to coronary quadratum.
Oh. Okay, so what we do is we look for, so normative values are not very reliable. So to say the nerve is enlarged on ultrasound, but typically if you're 14 millimeters squared or more, is not that reliable. What's more reliable, as you mentioned, is the discrepancy between the size of the nerve proximal to distal. If it's more than 2 millimeters squared, it's a high sensitivity and specificity. It goes up to 99% sensitivity under 100% specificity, 2 millimeters squared difference between the nerve proximal to distal. Nerve is also hyperemic. It becomes hypoechoic. It loses its echogenicity because of edema, and you lose the normal fascicular pattern. So again, it's not projecting very well. The converse of the MR now, the tendons are going to be bright, and the nerve is going to be dark as a normal finding. And as it gets big, it becomes darker. You lose the normal fascicular pattern, and there may be hyperemia on colored Doppler imaging. Treatment, well, you guys know that. Rests, division of the flexor retinaculum. And again, importantly, if there's a persistent median artery, in ultrasound too, you should look for the persistent median artery in ultrasound. If you're scanning an ultrasound and you see the median nerve, and it looks like a vessel that's really close to the nerve, that could be a persistent median artery. It's important to document it because when the surgeon goes in, he may cut the artery. All right, de Quervain's tenosynovitis. How often do you see that? Every day? Very commonly, right? So it's a tenosynovitis of the compartment 1 tendons, which is the abductor pollicis longus and the extensor pollicis brevis. Anything like twisting and driving of screws, mouse and trackball use, hobbies can cause de Quervain's. And again, most of these repetitive strain injuries are more common in females. Again, de Quervain's tenosynovitis is more common in females. And especially during and after pregnancy, and that may be due to the fluid retention. So what does it look, Decrovans tenosynovitis look like? What is the Finkelstein test, by the way? Anyone know? Positive Finkelstein test. Yes, you basically hold the thumb and you undeviate it and get sudden pain. Do you guys use ultrasound to look for Decrovans? It's a reasonable modality to look for it, but I think MR is a lot better. And the main reason is that the differential for Decrovans includes osteoarthritis or intersection syndromes. And if you do the ultrasound, you're not going to see osteoarthritis, right? So you're not excluding your differentials when you do ultrasound. So MR is a better modality to look for Decrovans tenosynovitis. So plain fluid, I'm sorry?
Are you saying the arthritic component of fluid around the tendon is communicating?
No, it's just the differential. First CMC osteoarthritis can resemble clinically Decrovans tenosynovitis. So if you scan an ultrasound and tendon looks fine and there's no tenosynovitis, you're still not excluding the other differentials. Whereas when you do the MR, you see the other differentials as well. Plain films, most times Decrovans, you don't see much. You may see a little bit of remodeling of the distal radius from the tenosynovitis, a little bit of calcification. That's really uncommon. But for MR now, this is axial T2s and coronal fat suppressed T2 weighted images. These are compartment 1 tendons, right? There's the abductor pollicis longus, extensor pollicis brevis. You can see the tenosynovitis around it. You appreciate the fluid around the tendon. See how the tendon is kind of focally thickened right here? That's classic Decrovans tenosynovitis. This is an early case. But this is a much more florid case of Decrovans tenosynovitis. You can see the extensive fluid around the tendon, the abductor pollicis longus. And if you look at the abductor pollicis longus, see how it's kind of fragmented? It's split. Now, you've got to be a little bit careful about that, and I'll talk about that in a second. And there's a lot of fluid around the coronal images and the sagittal images, a lot of fluid around the tendon. So tenosynovitis, synovial thickening, tendinosis, they're all exaggerated by the fact that the extensor retinaculum, as it wraps around the wrist, has a constricting effect on the tendons. So as you overuse your thumb like that, right, you get tenosynovitis, tendinosis, and then that constriction from the extensor retinaculum makes it worse. The other thing is that the abductor pollicis longus, when you see that, and you can see it in ultrasound too, not that well, you may see splitting of the tendon, but be careful about that because you can have a normal splitting of the tendon. The abductor pollicis longus can have numerous fascicles, like in this example from a cadaver, 1, 2, 3, 4 fascicles of the APL. So it's a normal finding. You can have a normal split of the tendon, it's a normal finding. But if you see fluid around it, like for example, this is normal splitting, but there's no fluid, that's normal. But there's splitting here, but fluid around it, that's pathologic, okay? That's Decrovans tenosynovitis. Decrovans tenosynovitis can be confused from a proximal intersection syndrome, and I'll show you an example of that in a second. How many intersection syndromes do you know? There are 2, proximal and distal. And schematics are always easier to look at. So the proximal intersection syndrome occurs 4 centimeters proximal to the joint line, okay? So whereas Decrovans is the abductor pollicis longus and extensor pollicis brevis tenosynovitis, what happens in an intersection syndrome with overuse, repetitive flexion extension of the hands, movement of the thumb, the compartment 2 tendons and the compartment 1 tendons. This is the compartment 1, abductor pollicis longus, extensor carpi abductor pollicis longus, extensor pollicis brevis. They're coming like that, and they cross over the compartment 2 tendons, which is the extensor carpi radialis longus and brevis. So with overuse of your thumb, you get a frictional effect right here, just proximal to the retinaculum. Do you appreciate that? So that's where you get your proximal intersection syndrome. But what is much less frequently recognized is a distal intersection syndrome. And that's where your extensor pollicis longus, or compartment 3 tendons, distal to the wrist joint now, crosses over the compartment 2 tendons. This asterisk here, that's Lister's tubercle. So when you palpate your wrist, you can feel Lister's tubercle, that little bump there. Okay? So the EPL is going to run to the side of it and sweeps over to go towards the thumb. So in overuse of the thumb now, this is going to rub up against these 2 tendons. So you get edema and tenosynovitis more distally. That's the distal intersection syndrome. And in the distal intersection, this is a proximal intersection syndrome. Axial images, coronal images. See how proximal it is to the wrist joint, where it crosses over? That's where the proximal intersection syndrome occurs. Decurvens tends to be more in that location. But the thing is, they can coexist. So when you scan for decurvens, you should also be scanning for proximal intersection syndrome. And again, that's where ultrasound is a little bit kind of iffy. When you're scanning for decurvens, always kind of go upwards and see whether there's a proximal intersection syndrome as well, because they oftentimes coexist. In the distal intersection syndrome now, this is a really fortuitous image. This is a coronal image on T2 weighted imaging. These are the compartment 2 tendons, and this is the extensive pollicis flocus kind of sweeping over it. So with overuse now, you get tenosynovitis. And there's several reasons why it can be quite significant. If you look at the orientation of the EPL as it comes around here like that, it takes an acute angle. So Lister's tubercle acts as a pulley on the EPL. So if you have spurring of Lister's tubercle, it can cause tendinosis, irritation of the EPL. And then the other thing is that in this area, the extensive pollicis longus has a watershed area, so it's relatively hypovascular. The other thing is that the synovial sheath of the EPL communicates with the synovial sheath of the compartment 2 tendons. So you get irritation from overuse, you get fluid in one tendon, it decompresses into the next tendon sheath because of that naturally occurring synovial foramen between the two. You get spurring here, that's going to irritate the tendons. And then you have the constricting effect of extensor retinaculum. So distal to Lister's tubercle is the distal intersection syndrome. So decurvens here, proximal intersection syndrome here, distal intersection syndrome here. Feel for Lister's tubercle. Trigger finger, do you guys do ultrasound to look for that?
Occasionally we'll do injections under it if it fails at the pond injection.
Okay. So in trigger finger now, the pulleys of the fingers, there are 5 annular and 3 cruciate pulleys. There are 8 pulleys, and basically those pulleys help to keep the tendons in place, okay? So your tendons coming down like that in your finger, and they're held in place by these little bands, these pulleys. The tendon that's the pulley that's normally affected in trigger finger is A1. It's right at the level. If you look at the sagittal ultrasound image here, these are the tendons, very fascicular pattern, okay? This is the metacarpal head. And this is your A1 pulley that's thickened. So ultrasound is actually really useful to look at trigger fingers because when you put your probe on the palmar aspect, you can see the thickening of the A1 pulley, but you can also put a needle in at the same time and inject it, or you can take a cutting needle and try and cut the A1 pulley to relieve the pressure. So this is an example of a normal, this is thickened A1 pulley, and this is a thin normal A1 pulley. So looking for thickening of the A1 pulley, and comparing it to adjacent fingers would be useful for trigger finger. Finger tendonitis, this is interesting. When you use your keyboard, interestingly enough, did you guys realize how often you use your 5th digit, your pinky? All these keys, theoretically, are done with your pinky. You know that? Because I type like this, so I don't know that. But yeah, finger tendonitis is not uncommon, amongst typists. And surprisingly, the 5th digit is fairly commonly affected. Flexor digitorum superficialis is the common tendon. We actually did a study. We looked at the tendons in kids, in young females of college age, where we looked at the mean intratendinous signal intensity of the tendons and compared it with biomarkers of inflammation, TNF-alpha, TNF-R1, and biomarkers of regeneration, which is TGF-B1. Interestingly enough, when we looked at the serum biomarkers, there was a definite higher amount of inflammation biomarkers in patients who were texting. I believe it was in excess of 500 texts a day. Yeah, these are college-age girls, right, between 18 and 22. So their biomarkers were quite significantly elevated. When we looked at the MRs, there was a little bit of increase in signal intensity, but what was really interesting is that when we did correlation of the serum biomarkers and biomarkers together, we got a great statistical correlation. Or look at the p-values. So what this shows to us, and if you look here, it's a negative correlation, is that there's definitely inflammation going on, systemic inflammation that's going on in these kids who are over-texting. And what's interesting is that the TGF-B1, which is a biomarker of regeneration, was actually negatively correlated. We couldn't really figure out why, but we presume it's due to a downregulation of repair and adaptation in high volume textures, presumably due to insufficient recovery time. So definite systemic inflammation is going on in people who are have overuse or overusing their mobile devices. I'll skip tendon rupture.
Can you speculate on what the long-term effects of that?
No, we did not. We did not. I leave that up to you. We're just radiologists. Sorry. All right. So lateral epicondylitis. Okay. What's more common? Medial or lateral epicondylitis? Don't look. Don't look at this way. Fair guess. Lateral, yeah, it's about 3 times more common. The population study done in Finland in 2006 of patients at wage earning age showed that the definite prevalence of 1.3% for lateral epicondylitis and 0.4% for definite medial epicondylitis. So lateral epicondylitis is far more common than medial epicondylitis. And there was an association, if you have forceful movements, it's not associated with lateral epicondylitis. If you have repetitive movements, it's not that associated with lateral epicondylitis. But if you have both forceful and repetitive arm movements, there's a positive synergism for lateral epicondylitis. In other words, you have to have both to really develop lateral epicondylitis. So the most common, this is a coronal T2 weighted image. I keep forgetting my audiences. I just assume that this is a radiology audience. So this is the humerus, that's the ulna, I'm sorry, that's the radial head, it's the ulna, and that's the common extensor tendon right here. It should be a dark structure. See the fluid bright signal in it? That's a little split in the common extensor tendon. And the most commonly affected tendon in lateral epicondylitis is the extensor carpi radialis brevis. This is the common extensor tendon, longus brevis, communis, and ECU. But it's the ECRB that's most commonly affected, and usually about 1 to 2 centimeters distal to its origin. So it's going to split right here. Okay. Another thing, when you're looking at lateral epicondylitis, this is an axial image and this is a coronal image. This is the common extensor tendon here. But you should also look at the radial collateral ligament because they can be injured at the same time, concomitantly injured. And also radial collateral ligaments can mimic lateral epicondylitis. The point being, look for gray signal for tendinosis, look for fluid bright, really bright signal for tearing, and also look for the underlying radial collateral ligament. The same thing applies to the ultrasound. You can use ultrasound to look for lateral epicondylitis. This is just another example of looking for the radial collateral ligament and the lateral ulnar collateral ligament. But an ultrasound, this is an ultrasound of lateral epicondylitis. This is the common extensor tendon. This is lateral epicondyle right here. Do you see the tendon coming down like that? This kind of hypoechoic area in the central portion, just distal to the lateral epicondyle, that's the area of tendinosis and tearing, and that's the common location for lateral epicondylitis. And that's what you look for in ultrasound, a hypoechoic area that may show a little bit of hypervascularity on the color Doppler imaging. Medial epicondylitis now is, as the name implies, on the medial side, or the third as common as the lateral side. And the most common location is at the junction between the pronator teres and the flexor carpi radialis. So just like on the lateral side, right, where it's kind of like central here, on the medial side, it's the same thing, right? It's at the junction between the pronator teres and the flexor carpi radialis, just like right around here, that you get the changes of medial epicondylitis. And just like on the lateral side, you should look at the medial collateral ligament too, on ultrasound as well as on MR. So this person's not the best example. A little bit of tendinosis here at the origin. And this is the medial collateral ligament. It's kind of a little thick. And then, why is this coming up now? Oops. I thought I had another slide, but it's not. Cubital tunnel syndrome. Any questions on epicondylitis? How do you guys manage epicondylitis, by the way? Injected? With steroids? Well, yeah, I mean, there's nothing wrong with that. What's the risk of injecting in steroids? Anything. Rupture, right? Progressive rupture. And that happens a lot in the plantar fascia too. When you inject for fasciitis, you get a plantar fascial rupture. The other important thing is that when you guys inject and you send a patient for MR, tell us that you injected, right? Because the injection can look identical to tearing of the tendon. So it's important to get a history, right? Because you take the steroid injected into the tendon, it's going to have a fluid bright gap at the site of injection.
How long will that last?
That I don't have a.
Depends on the volume of fluid.
Yes, I don't have a specific amount of days or weeks, but certainly in the weeks to months range. Cubital tunnel syndrome. We talked about carpal tunnel syndrome. This is the second most common compressive neuropathy of the upper extremity. So the cubital tunnel, whereas here it's the medial nerve, in the cubital tunnel, it's what? The ulnar nerve that's being compressed, okay, in the cubital tunnel. And this is probably what you'll see on occasion. Most times, again, it's idiopathic. You have your ulnar nerve coming down behind the medial epicondyle, right? As you flex your arm normally, there's a compressive effect on the nerve. The medial, the cubital tunnel actually has a mass effect on the nerve. So if you have anything inside of that cubital tunnel that will cause further compression, it's going to cause impingement onto the nerve and the cubital tunnel syndrome. Even chronic flexion, like in the old days when you used to have telephone operators holding a phone up like that all the time, the chronic flexion of the elbow, that cubital retinaculum, the medial retinaculum would compress on the nerve and they'll get cubital tunnel syndrome. So that's the medial epicondyle. These are the two heads of the flexor carpi ulnaris, and that's the aponeurosis between the two heads. And if you look at the UN, that's the ulnar nerve coming in right under that retinaculum. So that forms the cubital tunnel. And these are actual T1 weighted images. And I just wanted to show you that's the retinaculum here, that's the nerve, that's the medial epicondyle. That's the nerve, that's the retinaculum, that's the medial epicondyle. In some patients, and the incidence is 4 to 34%, that's a huge variation. You can get an anconius epitrochlearis or accessory anconius, and you get a muscle that replaces that retinaculum. And that muscle, on ultrasound, you can see it too. So if you're scanning an ultrasound and you see something that looks like it should just be a band where the cubital tunnel is, the retinaculum. If you see something that looks like muscle, anconius epitrochlearis, and that's going to cause impingement, narrowing of that space. So they're predisposed to getting cubital tunnel syndrome. This case I actually read just yesterday, and this is the plain film. It's got multiple loose bodies. Do you see that? Here on the medial side. If you look at the coronal T1 weighted image, this is the medial collateral ligament. So these loose bodies are actually intra-articular, inside of the joint space. But because they're inside of the joint space, it caused a lot of thickening and remodeling of the MCL. And that thickening and remodeling of the MCL is what caused the compression of the ulnar nerve. So the corresponding MR images now in the axial, sagittal, and coronal plane, look at this nerve. That looks like almost like a vessel. It's so bright. Do you appreciate that? It's an enlarged ulnar nerve. All of this is the enlarged ulnar nerve. All of that is enlarged. And very bright ulnar nerve. That's an ulnar neuritis. In a patient who had multiple intra-articular bodies, so it's not, the bodies are not inside of the cubital tunnel, they're inside of the joint space, but it was irritating the MCL, causing it to become thickened, and that narrowed the cubital tunnel space, and the patient developed ulnar neuritis secondary to that. Okay, it's more of the same. More of the same. Posterior interosseous nerve, radial tunnel syndrome. How often do you see that? Not very often. So radial nerve now, I won't spend too much time on this, it's really complicated. So radial nerve comes down now, right? And it divides. It divides into superficial branch and it divides into a deep branch. The deep branch is the posterior interosseous nerve, and this is a superficial nerve. This muscle is known as the supinator muscle. It has two heads, the superficial and deep heads. Right at that margin here of that muscle is a tendinous kind of edge to the muscle. It's known as the arcade of Froese, F-R-O-H-S-E. So the nerve now can come down, and with overuse of your arm, right, that edge of the muscle nerve, and you get posterior interosseous nerve syndrome. So once again spend too much time, that's the nerve coming down, that's the nerve coming down, then it splits. That's a superficial branch, which is purely sensory, and then the motor branch, which goes between the two heads of the supinator muscle. And when that happens, this is the arcade of Froese, right? That little black area around the edge of the muscle, that becomes thickened and overused and hypertrophied, and then it impinges onto that deep branch of the radial nerve. And they get a lot of pain and discomfort and loss of function in the upper extremity. And on imaging, because it's a compressive neuropathy, initially you get edema in the muscle, and then eventually you get fatty replacement of the muscle. And that's kind of standard for any kind of denervation. What happens in imaging is initially you get an edema pattern in the muscle, and then it gets edema and a little bit of fat, and then eventually in the chronic stages it becomes completely fatty replaced. So it's edema followed by fat replacement as the duration continues. So this is posterior interosseous nerve compression syndrome, and it's an under-recognized cause of a repetitive strain injury in the upper extremity. So when these patients come in and they have proximal forearm kind of muscle wasting and pain and loss of function, think of compression of the posterior interosseous nerve. All right, bursitis, well, everyone knows what bursitis looks like. Bursitis can be a normal structure, a bursa can be a normal structure, or you can get adventitial bursa forming at the site of pathology. So the most common repetitive strain bursitis that we see is bicipital radial between the distal biceps tendon and the radius, olecranon bursitis, and the subacromial subdeltoid bursitis. What's the main function of the biceps tendon? Supination, yeah. So with repetitive pronation supination, yeah, this is the radius here, that's the biceps tendon. You can get a bursa forming right here. That's the bicipital radial bursitis. This is olecranon bursitis. You know, people, kids and adults leaning against here, chronic repetitive injury onto the olecranon. This is a CT scan showing an olecranon bursitis right here. This is your classic MR subacromial subdeltoid bursitis. That's the rotated cuff right here, and that fluid around here, that's the bursal distension from subacromial bursitis. All right. So basically, I'm going to more or less stop here. In subacromial impingement, just wanted to make a point that with overuse, the arch, the subacromial arch, can impinge onto the cuff. And by impinging onto the cuff and bursalize right on top of the cuff right here, you get a subacromial subdeltoid bursitis. But it's also with a hyperextension or hyperabduction of the shoulder, that cuff kind of gets jammed up against the acromion and the AC joint space. So they end up getting, see how this looks frayed at the edges here compared to the nice smooth edge here? That's a bursal surface tear of the rotated cuff. And this is a problem because everyone feels that subacromial impingement is the major cause of rotated cuff tearing. But subacromial impingement really only is directly related to bursal surface tearing of the rotated cuff. And bursal surface tearing is only seen in about 5 to 10% of patients. So something's wrong with that pathology. If subacromial impingement is causing bursal surface tears and they're very infrequent, decompressing that subacromial arch is really not going to do a lot in a lot of patients. But in any event, for overuse, it's the subacromial impingement, bursitis, and bursal surface tearing that occurs. And then finally, thoracic outlet syndrome, debatable repetitive strain injury. So this is a sagittal image through, so this is like the neck, okay? This is the first rib, this is the anterior scalene muscle, the middle scalene muscle, and this is the brachial plexus in between the anterior and middle scalene muscles. It's been said that people with overuse, if you're overusing your shoulder, especially like when lifting heavy weights, it induces spasm and contraction and fibrosis of these scalene muscles. And the scalene muscles will then take the first rib and pull it out as it gets contracted, and it crowds that outlet, okay, and causes compression of that brachial plexus by the hypertrophy and elevation of the first rib. So it is sort of debatable, but patients with thoracic outlet syndrome, it can be a consequence of repetitive strain injury overuse. And then finally, the diffuse repetitive strain injuries. Do you guys treat that? Patients come in arm pain, you don't know what's wrong with the patient, right? No one really knows, and we don't know what's the reason for that, but there's been a couple of studies that says that one of the proposed etiologies is with a normal morphology of the median nerve in the carpal tunnel. So when they've studied these patients with chronic non-specific arm pain, and they did ultrasound of the carpal tunnel, they found that the ulnar nerve was not, the median nerve was not moving inside of the carpal tunnel. It's reduced mobility of the median nerve. And that's the proposed mechanism or proposed etiology for diffuse non-specific arm pain syndrome. And then finally, focal dystonia. Have you ever seen these patients come in with like, repetitive motions and like writer's cramp and musician's cramp, yes, right? And the theory for that is that in the brain you have specific maps in your cortex. And with overuse, you lose that kind of discrete maps in your brain, so it becomes kind of like blurred together. That's why they have like incoordinate function or mobility. You can diagnose that using functional MR techniques. All right, so that's a repetitive strain injury in a nutshell. Good posture is useful. There's a colleague of mine, Steve Ling, in bad posture, kind of horizontally oriented, eating grapes at the workstation. It's not good. This is much better. And all right, so that's repetitive strain injuries. Any questions? Just remember intersection syndromes, it's much more common than you think, and there are two forms. When you think it's Decker veins, it could be an intersection syndrome. They can coexist. And then there's a more distal intersection syndrome that you should know about. Field for Lister's tubercle.
You know, a good like reference for us in terms of like considered book versus stuff that's not like long.
Like a more basic book that talks about the. I don't know of any offhand. If I can think of one, I'll let you guys know. Okay, I'll do that.
What is your musculoskeletal textbook?
What textbook do I use? I use me.
No.
I'm teasing you. What?
Like what musculoskeletal radiology text do you recommend to your residents?
There's a book by Thomas Berquist. It's pretty thick though, so most residents don't really get around to reading it. They pick and select a couple of things from there, but not everything. I actually wrote a case review book that I recommend to the residents myself. That's case reviews, not really going to be that useful to you. Any questions? That was long, wasn't it?
Thank you.
All right, welcome.